So athlete's shoulder is exposed to extreme range of motion, to extreme forces and excessive repetitions. And it was shown in the article that more than 40% of elite athletes complain on shoulder pain at some point of their career. And the throwing biomechanics regarding the baseball pitchers is well known and well described, with the most difficult or most prone phases to injury, cocking phase and follow-through phase. It is described that there are large compressive forces and large shear forces on the posterior side of the joint, which are quite on the limit of the capsular resistance. But in Europe, maybe baseball is not so popular. We have some other sports which are popular and practice much more frequently. And for example, in this handball model, we can see that we have a wide variety of overarm and also underarm throwing techniques. And additional to this, the shoulder is exposed also to contact and to blocking. So we have heard already that shoulder pain in athletes can be due to acute trauma or chronic overuse injuries. And it is very important to know that the pain may come from 5 elements. This is capsule, scapula, the reason might be shoulder instability, rotator cuff problems, or biceps tendon. So it is very important that in clinical evaluation of the disabled shoulder, we made a comprehensive shoulder evaluation with evaluation of the range of motion, scapular dyskinesia, and so on, which was very well described already before by Berthe. So we have to know adaptive changes in the capsule to high force repetition, and we have posterior capsule contracture and anterior capsular laxity, and usually the total range of motion is shifted into the external rotation. But we have a problem when there is a significant loss of internal rotation, more than 20 degrees, so the arc of the motion is diminished, and we call this glenohumeral internal rotator deficit. So this model can explain us something what happened. Maybe we have some different ideas, or maybe this is not very consistent, but today we think that there is a lot of truth in this model. So everything starts with contracture on the posterior side, on the posterior capsule, and this leads to posterior superior shift of the center of the rotation, and there is a functional increase of the length of the anterior capsule, and the patient gains excessive external rotation. And then, because of this micro instability, we have peel-back forces to biceps and posterior superior labrum. There is also increased anterior capsular laxity, and this may lead also to torsional failure of the rotator cuff. So internal impingement is the second model, which can be very useful in practice. It is in position of the abduction and external rotation of the shoulder, and this is so-called kissing lesion when the rotator cuff comes into the contact with the posterior superior labrum. So we can observe injury to the posterior superior labrum and rotator cuff tear, and in the contact, this is a kissing lesion. So the main symptoms for the overhead patients is internal rotation deficit, external rotation weakness, and scapular imbalance. And the underlying pathology may be internal impingement, microinstability, slap or biceps lesions, and cuff tear. Usually, the MRI or MRI arthrography is the gold standard for diagnostic imaging, but you can find this is the same patient, and you can find the finding like this. It's a partial rotator cuff tear, you have a slap lesion, and some injuries to the posterior labrum. And this was very well described in the study of Yost. It is studied upon the handball players. They compared throwing shoulders, non-throwing shoulders, and the control group. And you can see that there is much more pathological findings in the throwing shoulders. And we have two main groups of the pathology. This is cuff pathology and posterior superior impingement or slap lesions. There is not much of instability. So this is very interesting. And from this study, we can conclude that there is a very, very poor correlation between symptoms and MRI findings, because it was shown that 93% of throwing shoulders have abnormal MRI findings, and on the average, there are 7 abnormal findings per shoulder, and only 37% of abnormal findings were symptomatic. So in clinical evaluation, it is very important to distinguish between adaptive conditions, asymptomatic findings, and symptomatic problems. So the main question, even for me, in the clinical practice is the finding the cause for the disabled shoulder? The conservative treatment is very important. It's very demanding. It's not an easy one, and it was very good explained before. Rotator cuff repair, it's a condition that when it is complete rotator cuff tear, we usually treat it operatively, but we have already heard that partial rotator cuff tear can be sometimes asymptomatic. The main symptom of the partial rotator cuff tear is the pain, the weakness only in minority. And sometimes we have a partial rotator cuff tear, like in this handball player, which sustained injury, it's traumatic one, in the Aber position. And it is exactly in the point like in the internal impingement. The results of surgical treatment of partial rotator cuff tear are not so good. You can see that only 50% of the overhead athletes can return to the competitive level. The next pathology which can be addressed by operative means is slap pathology. And the symptoms of the biceps tendon pathology are not very well reproducible, or it is very difficult to know when the biceps is the cause of the problems for the overhead patient. So there may be a pain on the bicipital groove or on the superior part of the shoulder. Maybe these problems are worse with throwing, and the patient may have additional signs. The slap repair, if the anchor of the biceps tendon is unstable, we can debride and then pass some sutures around the anchor and fix it to the superior glenoid. But the return to the pre-injury level is there is a wide range of those results. So it may be very bad or quite good. It is described that better results are with traumatic injuries. And the problem is that 10% of the patient gets a postoperative stiffness. Another possibility is biceps tenodesis. You can do it in mini open way, also subpectoral, or like in this case, in the level of the bicipital groove arthroscopically. And today, we are more prone to do biceps tenodesis with screws than with anchors. And I think this is important to know, especially in these 4 studies which was done in overhead athletes, that tenodesis has better results regarding the slap repair in terms of return to pre-injury level of sports activity. I have described that the main problem of overhead sports shoulder is also microinstability. And sometimes if there is a if there is a large instability connected with the pain, the patient may benefit from anterior capsular plication to get a balance into the shoulder joint, but you have to avoid over-tightening with this position of the arm, 70 degrees of abduction and 45 degrees of external rotation. This was proposed by some authors. And posterior labrum lesion can be sometimes a problem with pain on the posterior side of the shoulder. You can see the labral lesion like this, with also clinically with the signs of instability, of posterior instability of the shoulder. And in these cases, in symptomatic patients, we can decide for the posterior capsular repair. So results of surgical treatment are not as high as we would hope to be. So it is the repetition from the previous presentation. The conservative treatment is the first step to those athletes. I think that the whole message of this presentation is that this shoulder surgery in the overhead athlete is a meticulous one, and the patient should be very well evaluated, and you should not operate on him on the basis of the imaging findings like MRI findings. So to summarize, you have to know to recognize the adaptive mechanisms in overhead athletes. There are some specific shoulder injuries in overhead sports, and usually they are sport-specific. It is very important to recognize 5 elements and to evaluate all 5 elements. There is a poor correlation between MRI and clinical findings. Prevention and conservative treatment is very important. In traumatic cases, we go quicker to the operative treatment, and sometimes you need to do a shoulder rebalancing to address microinstability. Thank you very much for your attention.